I'm, as he says, the lead for the integrated and optimal care theme, and I'm just going to share my screen. Hopefully you can see that. Integrated and optimal care, how can we make care as good as possible for patients in an integrated way? And as John will have said, we heard from all of our stakeholder partners about what were the issues that affected them most. And two issues came out as common to all of our different stakeholders. And they were, firstly, the issue of frailty, and secondly, the issue of social prescribing. Under frailty, these are both areas where there's a lot of policy imperative to do something. It's clear that services need to be improved, and there are lots of policies about improving care. And these are changes that need to happen at a system level to make care more integrated. But although they all need to do something, services weren't really sure exactly what they should do, about what the best things to do were to improve care. So they're all doing slightly different things. If we think about frailty and end-of-life care, first of all, we've got an aging population, they've got increasingly multiple long-term conditions, many frail people living at home, and these are big users of health and social care. But our partners pointed out that there are policies around frailty, and there are also policies about end-of-life care, but often these are different ends of a spectrum, and many of the people who are currently frail eventually end up in end-of-life care. And rather than developing services in isolation, perhaps we could think about how we can see those services as on a spectrum and how lessons from one domain apply to the other, how people move from one service to the other. And then social prescribing, probably most of you know about social prescribing, but for those of you who don't, it's the concept of employing link workers in primary care. Maybe someone consults in primary care, the health service, but their main needs are in relation to family problems or housing or something like that. So the idea is that a clinician will be able to refer to a link worker who will be able to help the patient access a range of agencies and community support that might be more appropriate for them. Now that seems like a good idea, and it's national policy. But the evidence about how best to do it is very limited, particularly evidence about effectiveness and cost effectiveness. What models of social prescribing work best and for which groups of patients? And what problems need to be addressed to make it effective? So that's the second area of social prescribing that we need to look at. So we, in discussion with our various partner organisations, came up with 3 areas for research that we want to focus on. Firstly, under the heading of frailty, as I said, different areas are developing services in different ways. And we want to compare and contrast what the different areas are doing, different approaches, to see what seems to work best and how it can be improved. And at the moment, we're mapping the services that are available in the different areas and seeking to identify good candidates of models that can be compared with each other. And then secondly, related to frailty, is the question about how there's a lot of interest in stratifying the population into different levels of frailty to know where to focus your efforts. And one approach that's widely used is to use information that's in the electronic medical record and combining that into the electronic frailty index to identify frailty risk. And some of those patients also get clinical assessments, for example, using a comprehensive geriatric assessment. But there's also an argument that some aspects of frailty are best measured by asking patients themselves, using patient-reported outcome measures. And one question is, which of these measures are the best ways of identifying the people who've got needs? Maybe sending people a questionnaire and finding out from their perspective about their needs will be a better way of predicting their future risk of going into hospital than just using the information in the records. Or maybe both things should be combined, and we want to look at that. Under social prescribing, there are a lot of questions about effectiveness and cost effectiveness and the best ways to implement social prescribing. These are big questions of national interest, and in fact, NIHR have just announced large-scale funding for a national level research project to address them. And we think the best way forward for this question is for us to collaborate with other ARCs around the country in an application for funding for a large cross-regional project where we can collaborate. So there are our sort of medium-term priorities and things that we're working on planning up at the moment, but there are a number of things that are already going on and have been going on recently, and I'll just briefly mention those. Well, there are lots of these projects, but I'm just going to highlight three very quickly. One is the Rhapsody Project. General practices around the country have had to rapidly change the way they work because of the COVID pandemic to work providing remote consultations. And the Rhapsody study is an in-depth study of 21 general practices in which we're studying how they're making those changes and trying to learn lessons and then feeding back those lessons really quickly so that other practices can learn from the good ideas from their colleagues. The Respect Project. Respect's a national initiative to plan care in advance for people who are getting towards the end of their life so that their choices about what kind of care they might want in an emergency are known to everybody involved. And we're studying how that Respect initiative is being implemented in care and residential homes where advanced care planning can be really challenging. And the third example I want to mention is the de-adoption programme. De-adoption is about when the NHS needs to stop doing things that are of low value. And NHS England's identified a number of surgical procedures that have been done for many years, but aren't actually very effective. Well, they're only effective if certain criteria are met, and commissioners have got to try and reduce their use. So this project is seeking to understand how this policy of de-adoption is going, how clinicians and patients feel about it, and with a review to generating recommendations for the health service going forward. So those are just three examples of current work. But now I'm going to ask Heather Brant to tell you a little bit more about another example project in a bit more detail. Thank you.
Thank you, Chris. Let me just share my screen a moment. I hope you can all see this. So my name is Heather. I'm a researcher from ARC West, and I'm delighted to be presenting the Delays in Discharge study on behalf of the wider study team. And I'm also pleased to be joined by one of our public contributors, Sarah Biggs, and Dr. Kyra Neubauer, who was our clinical lead for the study. So this is a project that was conceived by Kyra, who's a consultant in geriatric medicine, and developed by Dr. Sabby Redwood at ARC West, but also conducted in collaboration with the ARC West Midlands colleagues. So despite many initiatives to reduce delayed transfers of care from acute hospitals, long delays continue to rise. Delays to discharge are increased when the patient is frail and elderly and admitted as an emergency. Discharge for these patients from hospital can be complex, involving numerous different professionals and organisations. These delays in discharge can cause patients and their families distress and are at substantial cost to the NHS, where delays with discharge have been estimated at around £820 million a year. These delays are also a concern for frail older people whose health and independence often deteriorate in acute care settings. And although social care funding cuts are one cause of discharge delays, it cannot explain all the delays. So we developed a study with the aim of understanding the delays that occur on hospital wards and to develop solutions to overcome hidden obstacles to effective discharge. And our question was, what are the clear obstacles and the less obvious or hidden challenges that impede effective discharge? So we conducted an ethnographic study. We observed 37 patient journeys, of which 11 were male and 26 female, from emergency admission to discharge and beyond. And that was on both care of the elderly and non-care of the elderly wards, over 22 weeks in the winter of 2018-19. And there was around 390 hours of observations documented. We also conducted interviews with health and social care professionals, patients, their family care members or caregivers. And as I mentioned, the study was conducted across two areas. So this was two hospitals, one in Bristol and one in Birmingham. And these were chosen because they varied in terms of local population, but also in hospital structures. So within our data, unsurprisingly, we found expected examples of delays, such as waiting for hospital investigations or specialist reviews, and delays related to community and social care provision. However, within hidden challenges, we found that patients were deconstructed, both on admission and during their stay, into numerous information fragments, including clinical investigations and diagnostic tests, professional assessments by a range of medical professionals, such as medical nursing, physiotherapy or occupational therapy, and also what is often referred to as collateral patient information. And this is information about a patient's home, their social and family circumstances, alongside their usual functional ability. So we observed, sorry, I should go back. So once patients are deconstructed, they need to be reconstructed in order to plan for their discharge. And we found challenges with this reconstruction, which was complicated by a number of factors. The first was a lack of continuity of care, and this was due to low staffing levels, staff shift patterns, and patients moving between wards. This then affected communication both within staff groups, but also between the patient and the families and staff. We also recognised issues with the collection, storage and retrieval of either electronic or hard copy patient-related information, and we observed factual inaccuracies and distortions in patient stories during professional conversations. Although staff often collected what is known as collateral information, it appeared to be of low status, or staff were unsure of its validity and would often recheck, resulting in patients and families repeating this information. And although there are a number of strategies to aid reconstruction, including multidisciplinary meetings or specialist discharge services, this reconstruction process can take time, particularly in the absence of good collateral information, thereby resulting in delayed discharge. Further, we observed issues with reconstruction leading to uncertainty. So this in turn increased risk aversion, and this risk aversion also led to further delays in discharge. I'd now like to hand over to Sarah, our public contributor, for her to share some of her experiences of being on the study. Thank you, Sarah.
Thank you, Heather. I was involved with other public contributors in this programme from the outset. And one of the issues that we raised quite early on was the study design and inclusion criteria, which initially was going to exclude patients who lacked capacity and also make sure that patients had 3 long-term conditions before they would be included. And we felt this really wasn't going to reflect the kind of patient we wanted to see this study explored, really, the kind of patient that has managed very well without any particular long-term condition, gets to the age of 90 and has a fall or whatever. And so we felt that that was unfortunate, and we knew it would be challenging for the researchers to include patients who lacked capacity. The capacity is a fluctuating skill set, and we knew that there were going to be patients who really, we needed to understand what happened to them, whether they understood what was going on or not. I'm really pleased that that was included in the trial research. The next thing we looked at is language. We struggled with the word collateral with its association with damage. So we felt it needs to be really simple for those who speak English or other languages. It's information about me. So we felt that was really important. And I'm still involved with this project, which is coming to the point where there are papers being produced. We have now come up with this wonderful animation, which you're going to see. For those of you who have sat in EDs with a relative, a friend, as a carer, for the hours on end while you're waiting for a bed, it's a really good opportunity to say to that friend or carer, tell me all about this patient. Let's get that information down now, because you've got nowhere to go and nothing better to do. So I'm really hopeful that every ED will be showing this animation that you're going to see, and also starting to encourage carers, friends and patients themselves to give you some of this information. If you know what normal looks like, how this patient functions on a daily basis as a clinician, you know what they're going to go back to. If you're saying this patient looks more confused than usual, or there's another issue, you don't know what usual looks like if you don't have that information. So we have had a local television broadcast really about the animation, which is great. And I'm hoping there'll be more national information going out about the findings from this research. Some of the narrative findings have been quite extraordinary and very moving. So I know that there's been some questions about the involvement that we have as public contributors. I'm happy to answer those later on, but hopefully that helps.
Thank you, Sarah. So as Sarah mentioned, we have several study outcomes. We've developed this animation that I'm going to show you in a minute, which was aimed at both patient and carers, but also for health and social care providers. And it was to identify the importance of collection, storage, and retrieval of all information, but especially social and functional information. We've also designed an information about me form. This is to collate and store all information about patients' social circumstances, normal cognitive and functional abilities in a single place that can be completed by patients, their families, and their caregivers, and can be shared with healthcare providers to ensure they have an up-to-date record to assist with a safe and appropriate discharge. We're in the early stages of discussions with our local stakeholders to explore how we can develop solutions. One of these is how the information about me form can be used and shared on an online and active platform used in the NHS. And we have had blogs hosted by the British Geriatric Society and the Royal College of Nursing, alongside 2 academic conference presentations last year, and have submitted our first publication based on these findings. And we plan to conduct further research in this field. So I'd now like to invite you to watch our animation.
If you or your family member are an older person living with frailty admitted to hospital in an emergency, you hold important information, which we will call information about me. Information about me is about your day-to-day life, where you live, how you look after yourself, and who supports or cares for you. It is important that the staff looking after you in hospital and those planning for when you can be discharged are aware of this information. During your stay, different staff will collect lots of different pieces of information about your health, tests, and treatments. As staff continue to care for you in the busy hospital, our research shows that information about me is not always collected, or may get lost or forgotten. When planning for you to leave hospital safely, all the different pieces of information need to be brought together. If the information about me is missing, it can be more difficult to decide what support you will need, and this may delay you leaving hospital. A longer hospital stay may also mean your strength and independence are reduced. But if all the pieces of information, including information about me, are available, delays can be avoided. You, your family members and friends can help by making staff aware of your information about me during your hospital stay.
So that's our animation. Thank you for watching. Please visit our website for further information, and I'll pop the link into the chat after this. I'd like to offer all my thanks to the study teams, both here and in Birmingham, those who participated, and would be very happy to answer any questions you may have. Thank you.